And HPI today, we have 15,000 hospitals all over India working to advance quality, ethics, and innovation in healthcare. Today, it gives me great pleasure to welcome all of you to this webinar. This webinar is on tendinopathy. So many of these cases we see in our practice. This webinar is jointly hosted by HPI and Pharmed. And this is the first in a series of sessions focused on this important topic of tendinopathy. The first one will be talking generally about tendinopathy, and later as we come along, we'll be focusing on specific regions. We are honored and delighted to have with us distinguished experts from all across the country, and look forward to their insights and perspectives that they will share. There have been a few minor changes due to some exigencies, and so I will continue to moderate this webinar today. Taking the program forward, it's my pleasure now to invite our keynote speaker, Dr. Bharat, to address us. Of course, Bharat needs no introduction. He's well known to the orthopedic fraternity all over the country. Starting off as president of the Bangalore Orthopaedic Society in 2018, he went to become Secretary General of the Karnataka Orthopedic Surgeon and Karnataka Orthopedic Association, and more recently, the organizing treasurer of IOCON 2024, which was held in Bangalore and which was widely acknowledged as a benchmark of excellence. He's also the chairman of the IOA CSRC. We are privileged to have him with us today, and Bharat, it's my pleasure to invite you to share your insights and set the tone for the rest of the discussions today. Thank you.
Thank you so much, sir, for your kind words. I'm just following your footsteps. Without wasting much time, we'll start off with the discussion. So I'll be sharing my screen now. So let's have an overview of what is tendinopathy. So what is a tendon? Tendon is basically a tough band of fibrous tissue which connects the muscles to the bone. It transmits the force created by the muscles to the bone, in which it makes the joint mobile. If the band is flattened, it's called an aponeurosis. The insertion site at the bone is called as an enthesis, which is usually accompanied by a small synovial bursa. So this is the tendon physiology. The tendon, as we go in deeper into the tendon, it's covered by the epitendon with the collagen fascicle bundles, which again have collagen fibers, which again leading on to collagen fibrils along with tenocytes. So this is a complex structure. It looks simple. So what are tenocytes? Tenocytes are fibroblast-like cells capable of producing type 1 collagen and other extracellular matrix molecules during growth and also during healing. This specialized microenvironment that supports a tendon cell progenitor cells are capable of self-renewal, clonogenicity, influencing their behavior and also their fate. It is primarily composed of the extracellular matrix with key components like collagen, proteoglycans, and various signaling molecules. It provides signals that maintains the stemness, promote differentiation, and regulate the tendon development, hemostasis, and also healing. So extracellular matrix, it comprises of 65% of dry weight of the tendon. It has collagen fibers which transmit the force. They are the force transmitting units, primarily comprising of type 1 collagen in the extracellular matrix. Type 3 collagens being the next abundant, it is critical in the pathological tendons and also helps in tendon healing. So non-collagenous matrix contains elastin, glycoproteins, proteoglycans, collagen, oligometric matrix proteins, lubricant, and tenacin C. Proteoglycans found within the tendons are categorized as small leucine-rich proteoglycans, with dicorin being the most prominent proteoglycan, accounting for about 80% of the proteoglycan content of the tendon. So these are various growth factors, IGF-1, which stimulates proliferation and also helps in migration, TGF-beta, stimulates collagen production and cell migration and regulates proteinase. PGDF, which stimulates the DNA and also protein synthesis. FGF2 regulates angiogenesis and also cellular migration. MMPs, which help in collagen degradation and also reorganization. VGEF, which promotes neovascularization, and BMPs to regulate the differentiation of the stem cells. So microscopically, a normal tendon has collagen fibrils arranged in a longitudinal pattern, which are slightly wavy. Tenocytes are long spindle cells which are not readily apparent. There are no fibroblasts or no myofibroblasts, and vascularity is very sparse within the collagen fibers in a normal tendon. Coming to tendon healing, the initial few days are known as the duration, the days of inflammation, wherein the formation of hematoma with invasion of cells for phagocytosis, which release pro-inflammatory cytokines. After certain weeks, there is proliferation phase with the deposition of randomly organized proteoglycans and collagen, increased cellularity and activation of TSPCs. The remodeling phase, which might go on for months to years, there is decrease in cellularity matrix production, transition from type 3 to type 1 collagen, and increased collagen fiber cross-linking. So the cellular mediators and the micromolecular mediators, as already mentioned, affect these different stages. Coming to the pathology of the tendon, which is known as tendinopathy. So various terminologies: tendinitis, which is chronic painful tendon accompanied by an inflammatory response. From the histopathological, biomechanical, and molecular studies, it is better described as tendinosis, as it is a culmination of multiple pathological processes. The term tendinopathy suits best. Let's understand the chronology. If the symptoms are for 0 to 6 weeks, it is called as acute. 6 to 12 weeks is subacute. If it is more than 3 months, it is considered as a chronic tendinopathy. The commonest sites are rotator cuff, Achilles tendon, medial and lateral epicondyle of the elbow, tendons in the wrist and hand, tibialis posterior and patellar tendon. Why is it more common at the insertion? Because the insertion sites are highly stressed. They're exposed to repeated strain, including shear and compressive forces. It is relatively less vascularized compared to the mid-substance of the tendon. The matrix composition of the insertion site also contributes for this. Etiology, the predisposing factors. The various predisposing factors, innate factors, usually in males above 40 years, anatomic variants and blood group O and genetic factors, acquired or nutrition, excessive stress, body composition, physical activities, which is new, poor technique, training error, high body weight, adiposity, and various other. Acquired factors such as decreased local vascular perfusion, repeated loading and excessive loading, abnormal and unusual movements, impingement, and new or old shoes or new equipment being used. So in general, the risk factors are the high body mass, leg length discrepancies, sedentary lifestyle with particular physical demands of occupation or sporting activities, laxity of joints, and also the genetic factors. So what are the mechanism of tendinopathy? The mechanical factors such as repetitive mechanical loads or excessive loads and also contusion. Also structural factors such as the morphology, the cellular and metabolic factors lead to fibrillar ruptures and the cellular and matrix lesions, which causes reactive tendinopathy. If there is optimized load after reactive tendinopathy, it goes into regeneration and adaptation, anatomical healing, with strengthening it leads to clinical healing. If there is excessive load even after tendinopathy, it leads to tendon disrepair and degenerative tendinopathy. So degenerative tendinopathy also with appropriate modified load bearing, it goes on to clinical healing. If the stress is greater than the physiological resistance, it leads to rupture of the tendon. So the mechanism is dysregulated apoptosis, mechanical overload, imbalance in the equilibrium between activity of MMPs and TIMPs, genetic factors such as polymorphisms in COL5A1, which encodes the type 5 collagen and MMP8, neuronal proliferation and also inflammation. So there are two theories: continuum model, where there is no inflammation mediated change throughout the course of these injuries, versus a failed healing theory, the inflammatory response throughout the course of the tendinopathy. What are the extracellular matrix changes? There's increased amount of collagen type 3, which is haphazard and irregular in alignment, increased glycosaminoglycans, increased aggregan and biglycan in mid substance of the Achilles tendon, increased fibronectin in Achilles tendon and supraspinatus tendon. The tenocytes are more rounded, look like enlarged lysosomes. Collagen fibers are angulated, vary in diameter, and have a buckling of the extracellular matrix 4. What is inflammation in tendinopathy? It's a clear signature defining the inflammatory mechanism has become apparent in a spectrum of tendinopathic diseases in both animals and humans. The key inflammatory interactions occur in the earlier, that is, acute and subacute stages of repetitive tendon microtrauma when the patients are most of the times asymptomatic. There are three distinct cellular compartments, that is, a stromal, immune sensing, and infiltrating compartments, each contributing to a complex milieu of inflammatory mechanism affecting the tendon homeostasis. Various cytokines implicated: interleukin 1 beta, which affects the ECM remodeling and reduced type 1 collagen production; interleukin 1 8, ECM remodeling and immune cell recruitment; interleukin 33, interleukin 6, tumor necrosis factor, which reduces the type 1 collagen and increases the pro-inflammatory cytokine production; interleukin 21R, pro-inflammatory cytokine reduction; and again interleukin 17, interleukin 4, interleukin 13, and interleukin 15, which reduce the tendon strength. So microscopically, the pathological tendon, the collagen fibers are not tightly packed nor well structured in their parallel alignment. The fibers are widely spread with a mucoid ground substance interspersed between them. They are present as more disorganized pattern. The tenocytes are more apparent and abnormal in shape. They lose their spindle shape and become more round and chondrocyte like, amounting to fibrocartilaginous appearance. The ruptured tendon, there are calcific deposits with less vascularity and less number of cells. This is how a tendon differs in normal and pathophysiological appearance, whereas there's increased cellularity of myofibroblasts, neovessels, the neovascularization, increased matrix protein, and the collagen fibrils are in a disarray, whereas in a normal bundle, they are tightly bundled. Coming to the pain in tendinopathies, it is due to the ingrowth of nerve endings and release of substance P and CGRP and glutamate. Also due to glutamatergic and inflammatory pathways which are active in painful human tendinopathy, despite there being no significant difference in basic tendon histology between painful and pain-free tendons. The severe chronic forms, so the pain is due to separation of the collagen fibers, due to neuronal cholinergic and catecholamine systems. There is change in peripheral neuronal phenotype in new painful human tendinopathies. Early diagnosis is quite difficult due to the absence of pain and functional limitation. Clinically, it is characterized by a gradual onset of stiffness in the tendon, activity-related pain, and decreased function. Sometimes there might be a localized swelling and a palpable crepitus. Clinical examination reveals pain with stretching and palpation of the pathological area. Common tendinopathies: rotator cuff tendinopathy, common cause of shoulder impingement, frozen shoulder, calcific tendinitis; decurrence tenosynovitis, more common in physical workers, diabetics, and rheumatoid arthritis; lateral and medial epicondylitis, which is more common in athletes and due to repeated stress. Achilles tendinopathy, it is about 5.9% in sedentary individuals and 50% in elite endurance athletes. It might be due to systemic conditions like inflammatory arthropathies, corticosteroid use, diabetes, hypertension, obesity, gout, quinolone antibiotics. The most commonest site is the mid portion in 55 to 65%, followed by the insertional site, that is insertional tendinopathy, and retrocalcaneal bursitis accounting to about 20 to 25%. Coming to the imaging in tendinopathy, ultrasound with color Doppler and MRI are considered the superior imaging modalities. It is prescribed when the tendinopathy is unresponsive to treatment and entails lingering symptoms. Imaging does not appear to have a major role to play in monitoring outcomes during surgical intervention for tendinopathy. So this is how a normal Achilles tendon looks on longitudinal and transverse images. The tendon appears echogenic with multiple parallel echogenic lines reflecting internal fibrillar structures. I don't know whether my arrow is visible. That is how it looks in parallel echogenic lines. Whereas in tendinopathy, patellar tendinosis, the longitudinal ultrasound of the patellar tendon near the inferior pole shows hypoechoic thickening. That is in figure A, the arrow shows hypoechoic thickening. The powered vascular Doppler study shows neovascularization of the tendinopathic region in figure B. The red picture is the figure B. Ultrasound of a rotator cuff calcification of the supraspinatus tendon, which shows a echogenic calcification within the tendon without any acoustic shadowing. It's a common feature of less mature tendon calcification. Coming to MRI imaging, there are two kinds of tendinopathy, mechanical and inflammatory Achilles tendinopathy. The figure A shows the mechanical tendinosis, which is more common in the posterior location, and figure B is the inflammatory disease, which is more common in the anterior location. Again, the sagittal section shows the mid portion in mechanical disease, figure A, and inflammatory, which is more closer to the enthesis, that is the attachment site is in the inflammatory disease. This is a radiological finding of enthesitis in 21-year-old man with ankylosing spondylitis. Figure A is the X-ray image, which is not very significant. B is a magnetic resonance image of the T1 sequence showing a small erosion at the greater trochanter, the site of gluteus minimus attachment. Axial T2 fat saturated sequence shows edema of the right gluteus minimus insertion consistent with enthesitis. So this is how MRI helps in diagnosing the condition. Coming to treatment, I'll not be speaking much into the treatment because there are other speakers who are going to cover it. There are various modalities such as NSAIDs, platelet-rich plasma, physical and manual therapy, shockwave therapy, load management, and also corticosteroids. So a broad overview, classical treatments are rest, eyes, NSAIDs, passive physiotherapy, orthotics, corticosteroid injections, active re-education with eccentric training. The more recent therapies are extracorporeal shortwave therapy, sclerosant injections, botulinum injections, injection of PRP, topical nitric oxide therapy, injection of MMP inhibitors, and stem cells and gene therapy. So these are the broad treatment modalities available, which will be covered in detail. Thank you for your patient listening.
Thank you, Bharat. That was truly wonderful and very, very interesting. I think your depth of knowledge and the clarity of the explanation and the ability to connect your clinical experiences with all what you showed. I think it's already started and enriched today's session. I think whatever you shared is not only academically valuable, but I think also highly relevant to the day-to-day practice of most of us. So thank you. We're grateful, and thank you for setting such a high standard for the discussions for today's webinar and the webinars which are going to follow. So with that, I'll go on to the next speaker. We have Dr. Amarnath. Dr. Amarnath, another very good friend, a very senior. Can you put the slide, sir, of Dr. Amarnath? Senior consultant. In fact, we trained together. We studied together in Davangere. He's a senior consultant orthopedic trauma surgeon and regenerative therapies surgeon, one of the few people in this area. The founder member, director of the Global Regenerative Orthopedic Sciences Foundation, the director of the Geriatric Orthopedic Association of India, the director of the Global Orthopedic Regenerative Sciences Foundation, chairman of the IOA India Osteoporosis Council, Secretary of the Geriatric Orthopaedic Society of India, and we do a lot of work together in sarcopenia, and also guest editor of the Indian Journal of Orthopedics with Springer. So thank you, Dr. Amarnath. Welcome to today's session, and over to you. Just a
Alex,
note, I think
thank
we
you.
will, we'll have the questions at the end of the session. So please send your questions in. And as requested, request the speakers to try and limit to 10 minutes. So we'll have more time for discussion. And I'll request Saru to just be helpful to the speakers by just buzzer at about 8 minutes. Thank you, Amar, and over to you.
Alex, thank you. Thanks a lot. I heard Bharat. I was literally walking towards the house, and fantastic. Now, I'm going to share the screen. I think Bharat has covered everything. I don't need to talk at all, I think, Bharat, isn't it? So in that sense, I should thank him. Truly.
I won't touch the
Absolutely.
treatment aspect, sir.
No, exactly. You know. So the one slide is enough, but it's in that sense of term.
Yeah,
So,
I think Amar is probably focusing on the medical management. So you can go into detail. Yeah. Right. Yeah. Over to you.
So yeah, sure. So now, just a minute. I'm sharing. Oh, it's not giving me this option here. Why? I'm just did that last week. It's asking me for OneDrive. I don't know why. Image from
Saurav,
file.
any tips, Saurav Arvind? Any tips to help Amar?
See, I normally present from my phone, and then I don't know why today it is taking some other link. Microsoft SharePoint में तो नहीं होगा. It's asking me for Microsoft OneDrive, which is I've not put in the OneDrive yet. It is there.
Saurav, otherwise, Amar, can you
share me
send
the
it?
slide, Dr. Amarnath?
I will do that. I will do that straight away now.
Yeah.
I'm going to share that to you, Saurav. If you could probably share that, and I can tell. Send a copy. PowerPoint presentation. I'm going to share it in WhatsApp. Is that all right?
Yes, doctor.
Hi, folks. Just bear with me. It's just a little time while this is being done. I'm going to be talking on the tendinopathies, obviously the medical management, how it can be managed. And Saurav has received the PPT. We'll just wait for him to upload that. For some reason, it is not allowing me to share. I don't know why. I'll try that again. Even if I were to do OneDrive, no, it's not going to be there.
Yeah, there we go.
Great. That is a quick saver, Saurav. Thank you, Alice. Thank you for the introduction, and I really appreciate the time and effort taken by AHPI and Format together to have the science together for all of us. The idea behind, next slide, Saurav, the theology and touched on the kind of challenges that one can go through by Bharat in such elaborate way. So I will not really read the slide, but I'll definitely make sense when you listen to me and add to that point together. That's the advantage. I would probably put the key factor for you. And looking at this as this juncture, now tendinopathy, obviously, none of us want to have pain. We don't want to have impaired functionality in our daily routine. So that's the biggest thing. In 10 minutes to talk about tendinopathy is going to be a very, very challenging one. In fact, as Dr. Alex was talking about, few sessions of these webinars going to happen, then we're going to have a focused group on each tendon that is causing us. And then there are so many window of opportunity for us to understand, discuss, integrate, and learn from each other. Next slide, please. Wonderful. Now, the biggest challenge, in fact, Bharat was talking about all the, areas of tendons from which point of problem it starts and where it goes. Many of us, we focus on the tendon insertion, but we also have the tendon where it's getting originated and the muscular layer, and then comes the tendon. So there is going to be an origin point and the insertion point. Yes, there is going to be a lot of stress in the insertion point, but I'm going to talk to you and then share my patient who went through recently. From an insertion point of view, all of us know, but from the origin point of view, how it has affected. Now, the inflammation of the outer layer is the paratendon, paratenon, we call it as. Paratendonitis is the inflammation of the sheet of the tendon. When it's in the tendon, in fact, Bharat has given all the details of where, what, how it's terminated, termed, and treated accordingly. Keep in mind, he also mentioned about a lot of cytokines which are coming there. He also mentioned about a lot of challenges. One ankylosing spondylitis, who had the challenge in his hip joints, tendons. Now, these are the things I'm coming to. We talk about tendon. As orthopedic surgeons, we talk about treating them, assessing them, and then managing them in our own methods. This is the key factor. To understand what it is and then to treat it becomes much easier. At the same time, you and I also look into the imaging and also the blood test, which is many of us may not look into it. So that's the reason Bharat had put a lot of inflammatory markers there. Hence, blood tests are extremely important to rule out the other variety of arthritis which comes into. He also talked about when is it acute, when is it medium, when it is called as tendinitis, when it's called tendinopathy, after 2-3 months. And then beyond that, all that needs to be understood very, very carefully. Next slide, please. Now, biggest thing, which I didn't see, which I don't see in many, many things, the last one I'm talking about, hamstring tendon. Because many of us have not focused on that. But yes, there are a lot more tendons than what this slide can show. But I'm going to be talking on all that. At the same time, the management will be part of the decision making of the treatment after we define the condition what he or she is suffering from, which is the most important point. Next slide, please. Yeah, so he's covered all these things. I'm not going to be taking much time. Next slide, please. And the time is precious. We will give more time for interaction, which is the key factor, and the more focused webinar for this day. So end of the day, what happens with tendinopathy, tendinitis, or paratendonitis? We have reduced activity, which is not agreeable in this day and age, or any for that matter. We want to have early recovery, early response from the treatment, and fast back to track onto our routine work. Is there a quick fix? Except for the name quick fix, as for the, there's nothing else. So there is a time given factor for the healing, like a time given factor for the baby to grow in the womb. Similarly, every tendon, every injury, every condition has a time limit. And also it depends on what each individual are involved in their activities. Next slide, please. Now, these 2 points are going to be talked by another colleague of ours, so I'll not touch into that. Next slide, please. Yeah, we all know, I think Bharat showed in one slide the entire mechanism of what can be done. So we will go a little elaborate, a few minutes, and then I'll wrap up very soon and take up the discussions later. Now, NSAIDs are the biggest thing. That is the key factor for all of us. It could be painkillers to start with, like a paracetamol, or it could be acetaminophen, it could be tramadol, morphine derivative, all that. So that is extremely important. And then we also need to look at how much to be given, how long to be given, and what is the comorbidities which Bharat was talking about. We need to titrate and manage the other conditions as well. We become literally the orthopedic surgeons become the orthopedicians or the orthopedic physicians treating this in that true sense of term. That doesn't mean that we are, degrading ourselves or putting our level down. No, we are orthopedic physicians and orthopedic surgeons by and large. So that is the biggest thing. And the next slide, please. Now, we have liniments, oils, whatnot, every other source that can be given some pain relief. The biggest challenge in the tendinopathy and the corticosteroids, whether it's going to be parenteral, whether it's going to be local, whether it's going to be injectable as a depot, doesn't matter. But when you're giving directly in a very active individual, you and I know. In fact, in the past, Alex and I, where we studied together in Mysore University in Davangere, JJMMC, we had injections clinic. People in our age group will know that today injection the others of what the corticosteroid give challenge. The biggest dreaded problem in a weight-bearing individual, in an active individual, is a rupture of a tendon, be it upper limb or lower limb. It is the physical activity in a nightmarish way. So we have to be that in the nascent stage now in a big way, for many out in a massive way, which is happening already. Now, this is where the whole challenge is. How frequently can I give injection? Should I include anesthetic? Can I do something else? Or
Amar, you're breaking up.
this is for corticosteroid point of view challenge.
Next
slide, please.
Yeah, you're better now. Yeah,
switch off the video. Yeah. I'll switch off the video.
Yeah, now it's okay. It's okay now. Please go ahead.
Hello?
Yeah.
Can you hear me?
Yes, Amar, we can. Please go ahead.
Wonderful, great. I appreciate it. Thank you. Next slide, please. Wonderful. Now, in the course of the development, what can be done? How can we reduce the complexities of the steroid injection? Variety of steroid injections are available, be it Transilon or I don't want to take the name of the brand, but steroid in that true sense of term has given a massive. Can you go back one slide before? Previous slide. Where are you? Hello.
Yeah, doctor. We are on the pharmacological therapy.
Wonderful. No, because initially I saw PRP and then suddenly it went to net. Okay. Now the next slide. Next slide.
Now we are on the PRP slide.
Wonderful. This is what I wanted to understand. Now, this revolution led to recover, regenerate, conserve, preserve, all that words put together of your own tendon, of your own ligament, of your own joint. This has led to a biggest revolution leading to stem cell therapy. Now, PRP, I know there are a lot of confusions. PRP is platelet-rich plasma. Now, there are other conditions where you say platelet-poor plasma, PPP. Where should I use? How should I use? When should I use? So these are the little issues. Can I give PRP to everyone? What is the kind of response? See, false claims are not accepted by anyone. At the same time, guarantees are not given to anyone. Be very, very clear on that. Let us be very clear in our approach. Don't false claim. And there is a lot of research which has been gone through in PRP. Now, in the PRP as well, there are so many other parameters which has come in. PRP is, all of us know, we take the sample of a venous blood, or it could be from a BMAC, bone marrow aspirate, and then take the Buffy code, which has the highest rich platelet rich, so that we inject into that particular inflammatory area, and you give the time to heal with the rest and the medications and the supplements, which is amazing. So that's going to change the history of the way you and I are treating. Now, we also have stromal vascular factors. This is taken out from your fat cells in your own body. We also have the allogenic, we also have autologous. All these combinations can be used in treating the tendinopathies, and the cost factor and the clarity, training, understanding, all that is required. In 10 minutes, we can't go into that segments, but we'll touch upon that. Next slide, Saurav. Thank you. Why? Wonderful. Now, this is again, Bharat was talking about, this can be used in a big way, but it has a small amount of function, definitely reduces the pain, and to a certain extent, the recovery for the regular work. Next slide, please. Now, this is where it can give you hope. Prolotherapy is there, stem cell therapy is there. Now, there's a huge amount of research which is being put on. And in fact, we are going to be launching a countrywide research program on this as well. So that is the biggest segment we're talking about in terms of the recovery. There are doctors who are using in our country for almost a decade and a half plus with good results. There's a lot of data bank which is missing from us. Let us collate the data and configure, publish, make it an evidence-based medicine so that the future users, the future generations, and others can get benefited from the kind of work, ethical work done by us. Next slide, please. Now, in fact, this is another thing which has given a big amount of impetus. But again, the cost factor is there. Hence, we don't use it in every patient because there are only few centers in the country in your own place where you're practicing probably. Hence, that's not being done in a big way. But yes, it has a big presence, big place in the treatment. So obviously, you can look at the tendinitis with calcium deposits and in chronic cases. I have done it for, especially for supraspinatus tendinitis, where we have calcium deposits happening. It has really, really worked very well. It is something very, very simple. You and I know we blast the kidney stones. The same thing. It is done. But again, it has to be focused, treated, and given the kind of waves, they measure it in a different wavelength and do it. And people have benefited in a massive way without having to undergo arthroscopic surgery, arthroscopic removal of these calcium deposits. Next slide, please. Now, this is exactly what I was talking about. Ultrasound guided procedures. Now, this is surgical. I'll not touch upon because surgical is going to be done by my colleague later. So let us go to the next slide. I'm just mentioning it here. This is taken up in a big way by him. Next slide. Great. Thank you. I think the time is coming up. Thank you, Saurabh. Summary table. Every tendinitis, be it trauma or any conditions with arthritis or arthropathy coming in, tendinopathy coming in, and we also have enthesites causing enthesopathy in the multiple areas, mainly where there's active mobilization happening. We see it more commonly in the ankle, tendo Achilles, what Bharat was talking and showing the figures for us. That is where the key factor comes into. Steroids have a minor to moderate role, and don't use it very, very frequently, and don't inject onto the tendon directly because that is going to make the tendons go like noodles. It'll just rupture. Let us not do that in a big way. Today, we have a choice, and using PRP, which is much more economical, you could prepare it in your own setup. If you're not having, if your setup is not equipped, you can definitely pick it up from the commercially available kits, which has done a very, very good, treatment protocols for the tendinopathies. Now, NSAIDs, you and I know, has a limit. Now, the biggest thing is in the pharmacological therapy, let us go to the supplements. It doesn't come under, many of them don't come under the DCGI, but DCGI and FSSAI comes into picture, and we have the supplements coming in. Next slide, please. So these are all the things coming up in a big way. I will be talking some moment on my next patient, what I did. Next slide, please. This is what I want to give one presentation of my case, and I'm going to wrap it up soon. Now, this is a 70-year-old man, as you rightly see there, fell accidentally in a wet floor when he's coming out from his bathroom and fell backwards, injuring his lower limb. He came to me having pain in the knee, got the X-ray done before come to see me, and I said, "There's nothing wrong in your knee. Why did you get your X-ray of your knee joint?" "No, my pain was too much there." Then clinical examination is the biggest key factor for all of us in an injury. I'm just sharing with one. That's the reason in the third slide I told you a lot of people don't focus on the origin of the tendon.
Amar, if you can wrap up in the next second.
No, that's it. Just 2-3 slides. That's all. That's all finished now. We are finished now. Next slide. So now see that what happens there. It is classic spot examination point for you. There is from the hip joint at the back of the thigh, there's a huge amount of bleeding happening. You know, hamstring tendon is torn there. He got an X-ray, which is normal, but obviously, next slide, please. When I said MRI, he said, "Oh, MRI, why? I have knee pain. You're organizing the MRI for this region." I said, "Yes, Baba, you have a problem there." And MRI very clearly shows there is complete tear of the hamstring tendon. How would you treat it? He is an active. He plays 4 days a week, 2 hours shuttlecock every 4 days. He walks 5 to 8 kilometers per day. 70-year-old active person. How would you treat? You know, he's as good as a young adult. Next slide, please. So the impression obviously is very clear. Now, complete tear of hamstring is there. And I'll also share some pictures of the MRI. Next slide, please. I'll show you some. Okay, what is now? This is exactly the reason. On the hip joint, you see the tendon. Down near the attachment of the tibia, you see the tendon. Here we have the biceps femoris, tendinosis, and semimembranous tendon. All that coming into a hamstring. Next slide, please. Next slide. What I gave to my patient. These are the things which I gave to him. This really helps. Extremely important. Next slide, please. What I treated him with. I said, you have to immobilize your knee joint because you're moving. That's where causing more challenges. His pain was coming down because the tendons were very lax and loose there. Next slide, please. Thank you. With this, I wrap up. And thank you for the time given to me, Alex. And
thank you, Amar. Yeah, thank you. It's very crisp and practical. I think for all of us, you covered the medical management in detail and the role of injections, systemic therapy, and the emerging biologics also helped to clearly to clarify the treatment landscape and offered real-world takeaways. So the next, of course, I'll call Santosh. Santosh is my colleague. We work together in Baptist. Santosh's slide, please, Saurav. Head of the Department of Orthopaedic Surgery and Sports Medicine at BBH. Specialized training in orthopedic sports medicine. He's known for his expertise in managing complex joint and sport-related injuries. And also his area of special interest is tendinopathies. In fact, he gave a lecture in the IUA in this subject. So over to you, Santosh. Request is to try and keep your talk within 10 minutes because we are looking forward. Already I've got a list of questions and we'd like to answer some of the questions also. If you can keep it at 10 minutes. And Saurav, if you can just alert Dr. Santosh at 8 minutes. Thank you. Over to you, Santosh.
Yeah, am I audible, sir?
Yes, yes.
Okay. So good evening, one and all. So I'll be briefly covering up the rehabilitation of tendinopathy, and this is the mainstay of treatment. And as all Dr. Bharat sir and Amarnath sir has mentioned about the basics pathophysiology, I'll not go into the detail. So it's a non-inflammatory condition, disorganized collagen, and failed healing response due to overload and systemic factors. So management outline: you should have a symptomatic and anti-inflammatory and adjunctive supplements. Exercises and interventions are the mainstay of treatment. So usually it's the initial diagnosis, presentation, and once you diagnose, then you plan for the rehab, which sometimes can carry up to a year if it's a major injury or major tendon which involving an athlete. So its return to sport is very debatable in tendinopathy. Coming to goals of rehabilitation, so reduce pain, which is usually helped with a very short period of splinting, depending upon the cause. If it's an acute overuse injury, then yes, splinting helps. But if it's a chronic one, splinting is never advised. Modalities of electrotherapy and all may play some role. NSAIDs definitely play a role in initial phases so that the patient is comfortable to start the rehab. Restore the load capacity of the tendon is the next goal of treatment. Improving the biomechanics and function, this is very important to understand, because just trying to improve for example, lateral epicondylitis, you try to improve only the strength of the extensors and improve, it will never improve, he'll recur. You have to improve the proximal muscles, so that biomechanics and function is very important, which also helps in preventing the recurrence. Now, coming to physiotherapy modalities, there are a number of modalities as mentioned here. Cryo, heat, manual therapy. Cryo is usually for the acute stages. Heat will come in later into the rehab sessions, and heat penetrates deeper. That's why heat comes later. Manual therapy definitely necessary for chronic therapies, which helps in mobilizing the tendon, facilitating the contractions, and all those things. And as Amarnath sirs were telling, you see, extracorporeal shockwave is a big thing, but as sir said, it's not available everywhere because expensive instrument. But it's easier, and definitely evidence-based approaches have shown that extracorporeal shock waves with the eccentric training has helped in tendinopathies. So key principles of rehab is load modification and not complete rest. Remember, do not rest the tendon if it's a chronic one. It will go in for more wasting and causes progressive degeneration. The progressive tendon loading is very important. Essentially, it's initial isometrics and slowly progress to dynamic. So the isometrics have already shown in literature to have an analgesic effect also. So initial isometric contractions have shown to improve your tendinopathies. Correct kinetic chain. Um, Importance of correcting the kinetic chain is very important. I'll show you in the next slide. And educate the patient on the expectations. You can't have a patient feel that okay, he'll return to sport within 2-3 weeks. It all depends upon the extent of tendon injuries and what kind of
Santosh, sorry,
yes.
the slides are not moving there for some reason. Now
Okay.
the key points are coming in.
Okay.
This is the first slide which has moved for some reason. Thank you.
Okay, sir. But I was able to show here. So my slides are.
It is not in the PowerPoint presentation mode. It's in the edit mode.
Okay, it was in the. So now just see. So now is it there or no?
We are able to see key principle of rehab.
Okay, just a minute, sir. I'll stop sharing, and I'll share the whole slide, complete picture for you. Entire screen I'll share now. So I'll share the entire screen so that is this okay, sir? Now?
Yes.
Now this is better.
Now
This is
full
better.
screen, doctor.
Yeah. So key principles of rehab. So it's load modification and not complete rest. I was as mentioning. Progressive tendon loading. Initially it's isometric and then progress to dynamic sharing. Correct kinetic chain defects, which I'll show you next slide, and educate the patient on expectations. So there are different methods of exercising, as you can see in the picture. It's here the biceps, which is contracting concentrically, and here it's contracting eccentrically. So in rehab, in literature has shown beyond doubt that eccentric loading is the one which will help more compared to concentric loading. And what about kinetic chain? In this picture, as you can see, a person is throwing a ball or trying to hit with a racket. His arm is the one which is going the ultimate force output, but energy generated is from the ankles, it goes up the hips and the torso, shoulder, and then. So if anything of this is not correctly rehabilitated, there is a chance of re-injuring his wrist or the elbow or the shoulder. So trying to improve his even the ankle strength and the quadriceps is very important when you are considering a throwing athlete. So this is how you have to analyze a patient, and rehab should be always titrated according to each individual. So phases of rehabilitation. Phase one is pain reduction with isometrics, as I've told you. So example, you have to hold it for longer time because it's an athlete, 5 repetitions of 45 seconds hold. It's just an example. Phase two is something called as isotonics with controlled concentric eccentric loading. There is something new which is coming up. It is being published old also in literature as old as 2010. Something called as heavy slow resistance. Always eccentric loading may not be tolerated by patients. So heavy slow resistance is given a heavy load around 70% of what they can tolerate and ask them to move slowly both concentrically and eccentrically. This also helps improve the tendinopathy. And plyometrics and sports specific energy storage drills, these are specifically kept only for the elite athletes. This can be avoided for the common man or recreational sport persons. So eccentric exercises, as the literature shows, has shown that it will improve the collagen cross-linking and helps facilitate the tendon remodeling and upregulation of insulin-like growth factors. And not all patients tolerate eccentric exercises, and then they should not leave the rehab, and that is why your heavy slow resistance comes into picture. And also informing the patient about the proper tendon loading, how much to be loaded, and also informing the patient there will be pain during and after exercise is very important. And monitoring this pain will definitely help in guiding the patient to have optimal recovery. So exercises are the crux of treatment, but how do you know that the patient is doing regular rehab? Are you able to send your physio there, or is he coming to your department every day? If it's not possible, then there are some apps like Rehab My Patient and some other BB imported apps which are there. And also Pharmat has their app called TendoCare Tendon Rehab Exercises Program, wherein if your email is registered and the password is unique, you can guide the patient to the exercise program, and also you can monitor how many times the exercises are being done as a very good feedback exercise program which everyone can start using. And these are the simple exercises, sample exercise programs, like how you have to give them. Writing in a paper and giving by a therapist will not help you. Always links to exercises videos are very important, whether they are able to do it properly, and the videos are also very important, and the photographs will help them do those exercises. So common pitfalls: complete rest leads to deconditioning, as I mentioned, returning to sport prematurely, especially in recreational athletes. They want to come back within badminton next week because they are being missed by their friends. And isokinetic, ignoring the kinetic chain and biomechanical errors will definitely lead to re-injuries, especially in elite athletes. And over-reliance on passive modalities, like most of the common men wants the ultrasound therapies or IFT as the treatment modalities. So criteria for discharge from rehab is full range of motion and strength regained, pain-free high-load resistance test, ensuring no pain in positions that normally compress the tendon, and full training with minimal pain. These are the requirements for criteria. When do you want to improve? Intervene or go for surgical methods or give some injections, and Amarnath Soros telling is no improvement at all at 12 weeks. But if there is shown improvement, we can still wait for another 12 weeks. Diagnostic uncertainty or suspected tear is there, and complex rehab in high-level athletes. So these are the things when you have to intervene and do some interventions. So summary: tendinopathy is load-related, not major inflammatory. Rehab is cornerstone of the treatment. Progressive loading is the key. Patient education is very crucial, and adjunct supports should not replace it, but rehab is the main thing. Thank you.
Thank you, Santosh. Very, very crisp, very clear, and very actionable. I think the structured approach to rehab planning, especially the emphasis on exercise progression and functional recovery, I'm sure it'll be useful to all of us clinicians. But thank you for making it so crisp and understandable. So now we go to
Yeah, I thank the HPI and Pharmat for that. So thank you. Thanks for this.
Thank you. So now I think we go to Dr. Krishna. We're all waiting to hear from him. Dr. Krishna, I'm sure all of us know, one of the senior orthopedic surgeons in the country. He's a senior consultant, Department of Orthopedics and Sports Medicine at Yashoda Hospital, and I had the privilege and pleasure of meeting him recently. He won the Best Innovative Research Scholar Award in 2020-21. Very involved in research. He was quite pleasantly surprised. We had some discussion on research, and he's one of the participants in the OASIS trial of 2010. 55 scientific papers indicate his academic bend of mind, 20 publications, 2 chapters in orthopedic textbooks, and a very, very hands-on and a very, very popular orthopedic surgeon in the Andhra Pradesh and the South. So thank you, Dr. Krishna, and over to you.
Thank you, Dr. Alex. Thanks for the opportunity given to me. And good evening, Dr. Amarnath, and Dr. Bharat, and Dr. Santosh. Now I'm going to share some of my thoughts on surgical management of the tendinopathies, which is one of the very, very common problems as a clinician we all face. As we all know that it's a very common chronic non-inflammatory tendon disorder secondary to overuse or repetitive strain, leading to the tendon collagen disorganization, and finally resulting in a lot of pain, loss of function, and because of the decreased quality of life. It is as high as 30% in both occupational and sports settings. Here we need to understand some difference between the tendinitis and tendinopathy. What I personally, why I put this slide is, commonly both the terms are used interchangeable. But tendinopathy by definition is a pathology of the tendon tissue itself, preferably in the mid-substance or incisional portion, which the previous speakers have clearly explained, resulting in overuse syndromes and degeneration. What are the surgical goals? Very clearly, Dr. Santosh mentioned, we have to wait at least for 12 weeks, or if there is a diagnostic dilemma, then we need to intervene. But the goals of this surgery in tendinopathy is to remove the degenerated tissue so that the damaged tissue need to be stimulated for the healing. If necessary, we need to repair it and do that. It can be by open methods, it can be arthroscopic methods, or it can be a minimally invasive method, depending upon the site and pathology of the tendon that is involved. But before embarking onto the surgery, we need to rule out the other secondary causes by doing a certain reasonable serological test to rule out the underlying inflammatory causes. And if they are positive, we need to address that before intervening surgically. So what are the indications, surgical indications in tendinopathies? The unresponsive patient for almost close to 6 to 12 months of conservative treatment, and in spite of some improvement, if there is a functional impairment resulting in disabling daily activities of living, and if there is a radiological correlation like an MR, and there is a clear-cut evidence of a structural degeneration which mandates a proper surgical intervention, all these need to be considered to take a surgical option. Now I am coming by region-wise. I am not able to cover the complete surgical here because of the paucity of the time. I give certain broad guidelines for the surgical interventions. Like, for example, one of the very common problems, rotator cuff calcific tendinopathy, is nothing but acute onset to the pain all of a sudden and difficulty lifting the shoulder or using the shoulder, restricting the motion, and acute onset of pain, patient as if there is acute cuff tear. You can see in this radiologically, you can see a very classical calcific hydroxyapatite deposition of the supraspinatus tendon. So one of the common methods in the OP is we do a ultrasound guided needling, which is a very minimally invasive and outpatient procedure. And we also add a saline or anesthetic lavage to break and aspirate the calcific deposits. And as Dr. Amarnath mentioned, for the acute inflammation to come down and pain relief, we may add some steroid provided there is no damage to the tendon. And the same thing, if the deposit is very huge, what we do is arthroscopic visualization of the entire deposit in the subacromial area, and under the subdeltoid bursa also, we directly visualize the deposit and try to remove slowly without damaging much the tendon. At the same time, we may have to do a subacromial decompression if there is a type 2 or type 3 acromion, which is causing further damage in the overhead abduction. And if there is a classical cuff tear, we can see in this clinical in these pictures very clearly. If there is a tendon tear, supraspinatus tendon tear, we need to repair the rotator cuff. Usually it is being done in a large full thickness tear identified during arthroscopy while removing the deposits. And also you need to understand the quality of the tendon after doing the the calcific deposition removal. The post debridement, if the quality is bad, we need to repair that. And it needs to be added. We need to do subacromial decompression and acromioplasty as in that particular patient as it demands, like type 2 or type 3 acromion. Then coming to the elbow, which is again one of the very common clinical condition, the lateral epicondylitis and medial epicondylitis. So tennis and golfer's elbow. We all know the common origin of the flexor tendons and the extensor tendons are the culprits. So what are the various surgical options? If the problem is localized and less severe, we can as well go and do a fenestration of the extensor carpi radialis brevis origin under local anesthesia. But if it involves a bigger one, so we need to do the excision and debridement of the degenerative tissue at the ECRB origin. And sometimes we may have to add a decortication at the attachment of ECRB or drilling of the lateral epicondyle to stimulate the healing. But it can be done by arthroscopy also, and it allows for the intraarticular inspection of the associated pathologies and can be addressed like synovitis, etc., which allows a faster recovery. Coming to Nischel's technique, where what we do a debridement and the microfracturing by removing the fibrous tissue around the origin and microfracturing or the epicondyle to promote the neovascularization. Therefore, that adds some tendon healing with good recovery. Then if the ECRB attachment is the tear is larger, we need to repair it using a proper suture anchor. Then comes to the hip area. The common problem is a bursa around the greater trochanter, or it can be a iliotibial band area problem, or it can be gluteus medius minimus tendinopathy. So I'm clearly gave both arthroscopy as well as open repairs of this one, where the open gluteus medius minimus repair is a direct incision over the greater trochanter. It exposes the tendon and the bony footprint nicely, and it's very ideal for a large and retracted full thickness tear of the gluteus medius using a suture anchor. As I told, it's preferred for complex, retracted, or a failed previous repair. Whereas endoscopy repair gives, it is when the tear is smaller, but the problem is it is limited only to small to moderate partial or focal tears of gluteus medius and minimus attachment. Then come to the trochanter bursectomy, the removal of the chronically inflamed bursa if the conservative management is failed. And often we need to combine with the tendon repair or IT band release if necessary. And a jetplasty of the IT band needs also to be performed whenever there is a ITB, external snipping hip syndrome coexists. And this reduces the compression at the greater trochanter and the pain relief. Then one of the common one, patellar calcific tendinopathy. Again, because of the repetitive overload or the patellar tendon, which is very clearly seen in both MRI as well as radiologically, we can see in this picture. One of the common ones is needle barbotage. It's early and minimally symptomatic cases where we use an ultrasound guided percutaneous needle so that the small deposits can be removed. But the deposit is large, as you can see in this particular case, very nicely, that can be done by open removal. As in this case, it's very large. It gives a complete removal of calcific and degenerative tissue. And at the same time, if the tendon is also torn at that particular area, we need to repair it. And arthroscopic advantage is we can look into the entire joint, and if the tendinopathy is small, we can remove it nicely. As I told, in this particular case, if the calcific deposit while removing it, if there is a significant tendon damage after debridement, we need to repair end-to-end. If necessary, use a suture anchor, and if necessary, you need to do a graft augmentation, preferably semitendinosis and chronicle or retracted tears. Then one of the common areas is tendo-Achilles tendinopathy. As Dr. Bharat clearly told, it can be at the insertional area or it can be non-insertional area. And it can be because of retrocalcal bursitis or because of the Haglund's deformity itself. The surgical options is, if it's a non-insertional area, you debride the degenerative Achilles tendon, remove the completely mucoid and calcified tissue within the mid portion of the Achilles, or it can be done, and it needs to be repaired. If necessary, use a suture anchor. Then coming to retrocalcaneal bursectomy, you need to excise the inflamed retrocalcaneal bursa, and this reduces the pain from the friction between the tendon and the posterior aspect of the calcaneum. Then the resection of the Haglund deformity, removal of the proud posterior lateral calcaneal prominence. It can be done either by central approach or can be lateral approach by tendon splitting approach, and this reduces the mechanical impingement of the Achilles tendon at the insertion area. If necessary, we need to repair the Achilles tendon at the insertion. It can be done by, again, suture anchor repair, or it can be done by endoscopic bursectomy, and calcaneoplasty can be also be done. And doing all these things, we need to understand that Santosh very clearly mentioned about the rehabilitation part. As it is true for the medical management rehabilitation, so also the rehabilitation is very essential following the surgical area. In this particular slide, I clearly showed each zone in the rotator cuff. You need to do immobilization for 2 weeks, then do immediate passive ROM, then progressive loading. You need to start at the end of 1.5 months, and slowly, as the pain is relieved, patient has to go to daily active living and sporting activity. So also with the lateral epicondylitis, so also gluteus tendinopathy. In this, we need to do an abduction pillow so that the repair portion of the greater tuberosity can be relaxed during the healing phase. So also patellar tendinopathy, we need to give a brace, a long knee brace, preferably for about a month, and crutch supported walking with partial weight bearing like this. In Achilles tendinopathy repairs or surgical options, we need to give a equinus cast or a boot for the initial healing time, that is for a 3 to 4 weeks time. Like this, we need to give the rehabilitation time for this one. And Dr. Amarnath mentioned about the role of the orthobiologics very nicely. And this is the area of our field of interest, which is having really gearing up a lot in our clinical practice. At every area, PRP and bone marrow aspirate concentrate has their own proving role slowly as we are getting more and more clinical data. And in the coming 1 decade, I think we get solid data to prove that orthobiologics have some or a definitive role in the treatment of tendinopathies too. So I conclude saying that surgical management should be selective and tailored to the individual patient with a failed treatment. You need to address the underlying biomechanics also along with the surgical aspect. Rehabilitation following the surgical aspect protocol is also an important point in the patient good outcomes. Orthobiologics are having a growing importance and promising tool in this area of the healing of the tendinopathies. With this, I thank the opportunity given to me by Professor Dr. Alex. Thank you, sir. Thank you very much.
Yeah, thank you, Dr. Krishna. Very comprehensive overview of surgical options. I think your discussion on case selection, surgical timing, and evolving techniques was very informative and well grounded in clinical wisdom. We are running a little behind in schedule, but I think we'll take some questions. We have got quite a few questions here. We'll start with Dr. Krishna. Question is, in your practice, have you seen success with endoscopic procedures for patellar or Achilles tendinopathy? And how does that compare with open techniques?
No, my clinical practice, I personally prefer an open technique.
Okay, right.
Compared open versus arthroscopy, open has more 360 degrees view of treating the patient surgically.
Okay, right. Thank you. I think that's very clear. And with your experience, I think all of us will follow that. Now, question to Dr. Bharat. What are the most significant misconceptions you see among clinicians or GPs? Quite a few GPs also handle tendinopathies, no? So when managing tendinopathies, what are the most significant misconceptions, Bharat? And there was one more. Is there a role for population level screening or preventive strategies in high risk groups like athletes or manual laborers?
I think definitely for athletes and manual laborers, screening can be done because they are the ones who are exposed to repetitive stress and unwarranted loading. As far as the misconception, I think the GPs and even, I mean, any general practitioner would definitely think that any tendinopathy is a chronic pain. They would advise some local liniment and massage. So that has to be, they have to be educated that it has to be treated with utmost care, like any other bone or joint pathology.
Thanks, Bharat. Now, coming to Santosh, the question is, how do you adapt rehab protocols for tendinopathies in less common sites like the gluteal or peroneal tendons?
So it all depends upon the patient's disability first, and always compare the strength, and the clinical findings always matter a lot. Initially, MRI might become expensive in most clinical settings because the patient may not be affordable. If they're affordable, getting a MRI will tell us how much is the extent of the tendinopathy involved. With the extent involved, we can start the rehab program. If it is very thick, I mean large inflammation, definitely NSAIDs can be given for some time, along with the nutraceuticals like Tendocare itself, because the nutraceuticals also studied well. It depends upon how big is the size of the collagen you're giving, because if the larger collagen, then it will automatically will not bypass the gastric digestion and it will be digested. So some collagen molecules which are smaller in size can be absorbed directly. That is what the literature says. So you can add that supplement, because you cannot just wait for the rehab. Patient has to be happy with you. So practically speaking, you will have to reduce the pain initially, and then you start with the rehab program what the patient can tolerate. Because hip is one gluteal tendon, we can have pain on normal walking also, like how we do for hemiarthroplasty and IT fracture fixations. We can give a crutch on the opposite side initially to reduce the load, and then the physios will take over by guiding the patient and taking him into the confidence. So obviously, repeat imaging is never necessary until unless you find that your rehab or nothing is improving. So that, as Krishna sir was telling, we can do a like a tendon repair or debridement, open or arthroscopic, in case there is no improvement after end of 3 months, 3 to 4 months.
Okay, I think it's one more. I thought we'll have one question, but I think this is an important question. With so many patients and the public going to YouTube and Google, etc., for online exercise elements, we don't know which is safe, which is not safe. How do you guide them to safe and effective resources? You got the question? Yeah.
Answer. So, I mean, getting them, the most important confidence level is we have to tell them what has happened to them first, and then come back to them and say that there are innumerable number of exercises on YouTube. Also, they will tell us whenever you prescribe a rehab program, they'll tell, I will do it in seeing the YouTube. But whether they're doing it correctly or not correctly is very important, and that is why your physio supervision is very important for that. And that physio should be the one who will be able to give you a feedback. That is very important, sir. Not like a physio, the third physio, who the patient will tell you that he's doing the exercises, but you don't know how the exercises are being and how is he doing it. So in that scenario, YouTube alone or the WhatsApp university, now some people call, is not helpful. So guiding either a good physio who's into sports medicine or a doctor who is monitoring him is very important.
Yeah, and I think the other one, I think there was another question about any video reference for exercises. So I think our partner in this format, I think they've got a very excellent set of exercises. So thank you, Santosh.
There are other questions also, sir, like what are the best medical treatment options for chronic TA tendinitis? I think like Amarnath sir and Bharat sir can answer that. Any experience about PRP or OSI next? That is asked, sir. And PRP questions are there basically.
Yeah, there are. I'm not asking all the questions because of paucity of time. We've already gone
Okay, sir. Okay.
past. So there's one for Amar now. Did the patient with hamstring tear heal completely, and much time? How much time, and what was the decision taken to start physio in such a case? Amar?
Wonderful. Thank you. Hope I'm audible and clear.
Yeah, yes, you are.
Great. Now, I think there was a network issue, so we logged into a couple of units, so no issue. Great. Now, this hamstring, even it can happen in a young adult, or what I showed in a 70-year-old active, in fact, more active than any young adult. So that was the biggest thing. When once a diagnosis was made, MRI scan confirmed, like somehow the images are not uploaded, I don't know why, doesn't matter. Now, it was a complete tear, and then all the coronal section, sagittal, and the axial section showed very clear-cut collection of fluid and all that. So the recovery will definitely be there. Give the time to heal, rest the tendon initially, and then the therapy, the question which comes to when, what, how much. Initially, I gave the anti-inflammatory, rest with because I cannot spling the whole hip. The advantage was to give him the knee brace so that the hamstring tendons are relaxed. He recovered well. Ice pack was the biggest thing to reduce the inflammation and the pain. Two, in fact, many people talk against collagen. See, as long as it doesn't do any harm, there is no harm in giving it. That's what I say. Two, and rightly said, Santosh was talking about the collagen molecule itself. Because by the time the collagen is digested, it can go into the amino acids and then it may work, it may not even work.
Right.
So that's the kind of thing which comes into picture. So I would supplement collagen immaterial, whether it helps or not, unless they're allergic to some of the parameters. Here, the collagen is type 1, 3, 4, 5. 2 especially for synovial, cartilage to develop. So I don't use 2 for this, but tendinopathy is 1, 2, 1, 3, and 3, 4. There are quite a few of them.
Yeah,
and then rehabilitation. Rehabilitation is done usually when once the pain is better, as Santosh is talking about, we should make them move within pain limits. So this gentleman, I gave the knee brace within the pain limits, what he could do. And in fact, I have the pictures for some reason, as I told you, it didn't upload the videos as well. Now, he is able to do, I saw him about 10 days ago. He's recovered pretty well, 95% recovery. He's back to playing shuttle badminton twice a week, and he's doing regular 5 to 7 kilometer walking per day.
Okay, and he's a 70-year-old man, no? So very good to hear.
70-year-old man.
Yeah, right, good. So thank you, Amar. So I think there are a lot of other questions, but we'll organize for this to be, because we have already gone 10 minutes beyond the scheduled time, and we are quite particular about time, but this is our first one, so apologies for that. So thank you all. I think there was some request for some slides and presentations. Please get in touch with us, and we'll make it available to you. I think we've got such interesting insights from truly remarkable experts from all over the country. So thank you all once again. So as we come to the end of this session, once again, my heartfelt thanks to all our speakers. I think excellent job. There's so much of information, and I think we did a remarkable job in condensing it to an hour. Thank you for this, your contributions. Very special word of appreciation to all the participants. I think we had 200 participants at one time who joined us and engaged so actively, and apologies again that we couldn't answer all the questions, but we'll do it post the session. Thank you once again to Farmint for their collaboration and continued support, and of course to my own AHPI for facilitating this important initiative. This is the first orthopedic initiative that we're doing in AHPI, and I'm going to take Krishna's help with all of you to make it a little more frequent and make it something that all orthopods look forward to. So the next webinar, I said this is a series of webinars. The next webinar will focus specifically on the shoulder tendinopathies. Probably in about 2 months, we'll keep you informed, and we look forward to your support. So thank you all once again. It was a pleasure having all of you, and we wish you a pleasant productive rest of the day. Thank you very much.
Thank you.
Have a nice
Thank you, sir.
weekend.
Good
Thank
night.
you. Thank you, Alex.
Have a nice
Thank you.
weekend, sir. Thank you. Thank you, sir.
Thank you. Thank you.
Bye.
Thank you.
Bye.
Bye. Bye.